Ma'am, it's already 5:30, 3:30. With all your permission, I'm starting this session.
Yes.
Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Veena Shinde, ma'am. Ma'am
Good
has
afternoon.
done MBBS, MD, Obstetric and Gynecology, DGO, PG in Assisted Reproductive Technology, and consultant at Shinde's Medicare Hospital and Spartan IVF, Mumbai. Today, she is going to discuss on a topic management of preeclampsia. Let me tell you overview of the topic. Preeclampsia is a serious complication that occurs during the pregnancy, and it is characterized by the high blood pressure and damage to organs, most probably the liver and kidneys. The management of preeclampsia aims to prevent complication and ensure the safety for both mother and the fetus. To know more about this topic, I would like to invite ma'am and hand over this session to you. Over to you, ma'am. Kindly proceed from here.
Preeclampsia is a complication of hypertension during pregnancy. There's a classification of hypertension: gestational hypertension, preeclampsia, eclampsia, superimposed preeclampsia, and chronic hypertension. Gestational hypertension is hypertension that when the BP is 140/90 without proteinuria occurring after 20 weeks of gestation. Transient diagnosis with normalization of BP by 12 weeks may represent a pre-proteinuric phase of preeclampsia or hypertension abated in mid-pregnancy. It may evolve to preeclampsia, and it is a retrospective diagnosis. Chronic hypertension when the BP is 140 diastolic and 90 diastolic, predating conception. It is identified prior to 20 weeks of gestation. It persists for more than 12 weeks postpartum. Use of antihypertensive medications are there before pregnancy. Classification of hypertension in pregnancy: preeclampsia and eclampsia. When it occurs after 20 weeks of pregnancy, it is preeclampsia. A BP of 140 systolic and or more than 90 diastolic or higher, proteinuria 0.3 grams protein or higher in a 24-hour urine specimen, or 1 plus per dipstick, or protein ratio of more than 0.3. In the absence of proteinuria, new onset hypertension with the new onset of any of the following: thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. Eclampsia is the presence of new onset grand mal seizures in a pregnant woman with preeclampsia. New onset seizures 48 to 72 hours postpartum. Other central nervous system pathology is the likely reason for the seizure after 7 days. Rule out idiopathic seizure disorder or other central nervous system pathology such as intracranial bleeding, hemorrhage, arteriovenous malformation, or ruptured aneurysm. Classification of hypertension: superimposed preeclampsia, new onset in a woman with hypertension prior to 20 weeks, sudden increase in proteinuria if already present in early gestation, sudden increase in blood pressure, development of HELLP syndrome, development of headaches, scotomata, or epigastric pain. Hypertension in pregnancy is common and complicates obstetric practice in India. Incidence of preeclampsia in hospital practice in India varies from 5 to 15%. Incidence of eclampsia is about 1.5%. The etiopathogenesis involves immunological factors, genetic factors, environmental factors, placental dysfunction, and hypertension, proteinuria, eclampsia, and HELLP syndrome. The clinical risk factors for preeclampsia: primiparity, previous preeclamptic pregnancy, chronic hypertension, renal disease, history of thrombophilia, multifetal pregnancy, in vitro fertilization, family history of preeclampsia, diabetes mellitus, obesity, SLE, advanced age. Preeclampsia with the absence of severe manifestations often has been characterized as mild. It should be noted that this characterization can be misleading even in the absence of severe disease. Morbidity and mortality are significantly increased. Therefore, the term preeclampsia without severe features is to be used instead. A systolic blood pressure of more than 160 and a diastolic BP of more than 110 on 2 occasions at least 4 hours apart while the patient is on bed rest thrombocytopenia, a platelet count less than 1 lakh per microliter, impaired liver function as indicated by abnormally elevated blood concentrations of liver enzymes, severe persistent right upper quadrant or epigastric pain, unresponsive to medication and not accounted for by alternative diagnosis or both, progressive renal insufficiency, pulmonary edema, new onset cerebral or visual disturbances. What are the complications of preeclampsia? ARDS, pulmonary edema, cardiomyopathy, generalized edema, eclampsia, severe cerebral hemorrhage, altered mental status, acute tubular necrosis in the kidney, acute kidney injury, glomerular endotheliosis, periportal inflammation, hepatic dysfunction, hepatic hematoma, acute fatty liver of pregnancy, and in the hematological thrombocytopenia, DIC, microangiopathic hemolysis, venous thromboembolism. So as you see, it is a very complex disease. The first trimester risk assessment for early onset preeclampsia. Bed rest is only recommended screening approach for preeclampsia. Taking a detailed history to evaluate for risk factors is currently the best and only recommended screening approach for preeclampsia. It should remain the method of screening for preeclampsia until studies show that aspirin or other interventions reduce the incidence of preeclampsia for women at high risk based on first trimester predictive tests. Current predictive tests for preeclampsia may harm more than they benefit because of their low positive predictive value. As you can see, bed rest is important. What is the goal of treatment? To maintain a safe blood pressure, to monitor the mother for deteriorating disease, to monitor the fetus for signs of placental dysfunction and growth restriction. Women with medical history of early onset preeclampsia, preterm delivery at less than 34 weeks, preeclampsia in more than one prior pregnancy, initiating the administration of low-dose aspirin beginning in the late first trimester is suggested. Meta-analysis of more than 3 lakh women in randomized trials of aspirin indicates small reduction in incidence and morbidity of preeclampsia and reveals no evidence of acute risk, although long-term fetal effects cannot be excluded. Administration of vitamin C or vitamin E is not recommended. Dietary salt restriction is not recommended. Bed restriction and restriction of physical activity is not recommended. When you restrict the dietary salt, the iodized salt is not going to the fetus, so that can affect the fetus. Bed rest can cause lots of weight gain, and that can further complicate the hypertension. Management: gestational hypertension, systolic BP of 160 and diastolic of less than 110 without severe features. Evaluation: initial evaluation, mother's evaluation with CBC, platelet count, serum creatinine, liver function test, urine protein 24-hour collection, symptoms of severe preeclampsia, ultrasound of the fetus, amniotic fluid index, non-stress test, biophysical profile if NST is non-reactive. Continued evaluation of the fetus, that is the kick count daily, USG every 3 weeks, amniotic fluid volume once a week, NST weekly, and in the mother, blood pressure checkups twice a day, evaluate proteinuria, laboratory CBC, liver enzymes, serum creatinine once a week. Advice to the patients: women are instructed to report symptoms of severe preeclampsia, that is headache, visual changes, epigastric pain, shortness of breath. Advised to immediately come to the hospital if they develop persistent symptoms like abdominal pain, contractions, vaginal spotting, rupture of membranes, or decreased fetal movements. Antihypertensive therapy, the Cochrane review, no consensus regarding the management of non-severe hypertension. Therapy may decrease progression to severe hypertension, but also may be associated with impairment of fetal growth. A recent systematic review of 46 trials evaluated BP control in women with mild to moderate hypertension. The authors concluded that it is unclear whether antihypertherapy is worthwhile. When to initiate antihypertensive therapy, the NICE recommends commencing therapy when BP exceeds 150 by 100, and the FOXY recommends treatment only for blood pressure over 160 by 110. Avoid reducing the blood pressure below the lower limits, that is 110/80, which would lead to risk of placental underperfusion. Antepartum management, bed rest. A Cochrane review of 4 randomized trials that compared bed rest with no rest in pregnant women with mild hypertension found sufficient evidence to provide guidance for clinical practice. Bed rest not to be prescribed. Timing of delivery less than 37 weeks of gestation. Expected management with maternal and fetal monitoring is suggested. Beyond 37 weeks, delivery rather than continued observation is suggested. Hospitalization and delivery for one or more of the following: 37 weeks or more of gestation, suspected abruptio placenta, 34 weeks or more of gestation plus any of the following: progressive labor or rupture of membranes, ultrasonographic estimation of fetal weight less than 5th percentile, oligohydramnios, persistent VPP 6/10 or less. Intrapartum management, magnesium sulfate prophylaxis. Universal use of magnesium sulfate therapy in preeclampsia without severe features is not recommended. Certain signs and symptoms have traditionally been considered as premonitory to seizures and should be considered in the choice for initiation of magnesium sulfate therapy. Clinical course of women with preeclampsia without severe features can suddenly change during labor. All women with preeclampsia without severe features who are in labor must be monitored closely for early detection of progression to severe disease. Magnesium sulfate therapy should then be initiated if there is progression to severe disease. If it is 37 weeks or more of gestation or 34 weeks or more of gestation with labor, rupture of membranes, abnormal fetal test results, ultrasonographic estimation of fetal weight less than 5th percentile, suspicion of abruptio placenta. If it is less than 37 weeks of gestation, inpatient or outpatient management, maternal evaluation twice weekly, fetal evaluation with preeclampsia twice weekly NST with gestational hypertension, weekly NST. 37 weeks or more of gestation, worsening maternal or fetal condition, labor or premature rupture of membranes, delivery of the patient, prostaglandins if needed for induction. Management of mild gestational hypertension or preeclampsia without severe features. Treatment of severe disease, severe hypertension, severe preeclampsia. It can be a feature of essential or gestational hypertension, but may also represent progression to full eclampsia. What is the objective of treatment? Prevent potential cardiovascular, renal, cerebrovascular complications related to uncontrolled severe hypertension. Patient should undergo a full evaluation including urine and blood tests to detect or new onset preeclampsia. Target of treatment should maintain the BP at 150/100. Blood pressure should be checked every 5 minutes while attempting to gain control, and if refractory, consideration should be given to invasive monitoring. A updated Cochrane systematic review of 35 trials that involved 3,573 women found no significant difference regarding either efficacy or safety between hydralazine and labetalol or between hydralazine and any calcium channel blockers. Theoretical concern exists that the combined use of nifedipine and magnesium sulfate can result in excessive hypotension and neuromuscular blockade. Choice and route of administration of drugs should be based primarily on the physician's familiarity and experience. Adverse effects and contraindications to the prescribed drug, local availability, and cost. Acute onset severe hypertension during pregnancy and postpartum period. Intravenous labetalol and hydralazine have been considered first-line medications for the management of acute onset severe hypertension in pregnant women and women in postpartum period. Immediate release oral nifedipine also may be considered as a first-line therapy, particularly when IV access is not available. Above drugs do not require cardiac monitoring. Emergent consultant with an anesthesiologist, maternal fetal medicine subspecialist, or critical care subspecialist to discuss second-line intervention is recommended if above drugs fails to relieve acute onset severe hypertension. What are the antihypertensive drugs used in pregnancy and lactation? Atenolol, avoid in first and second trimester, associated with fetal growth restriction. I have seen fetal death also with atenolol post-delivery, so it is better to avoid during pregnancy. Captopril, ACE inhibitors, it is not associated with severe fetal anomalies, fetal nephropathy, or intrauterine death. Enalapril, that is ACE inhibitors, it is not associated with severe fetal anomaly, fetal nephropathy, and intrauterine death. In the breastfeeding period, atenolol, no known evidence of harm. It is a second line of treatment after labetalol. Captopril, manufacturers advise avoid, however recommended by SOGC. No known evidence of harm. Enalapril, not for preterm infants. No known evidence of harm, particularly for women needing cardiac or renal protection. Postnatal atenolol, yes. Captopril, yes. Enalapril, yes. Side effects of atenolol, risk of fetal growth restriction and bradycardia in pregnancy. Captopril and enalapril side effects are cough. Contraindication is asthma of atenolol. Labetalol, it is a beta blocker. It can be given IV for rapid onset of resistant hypertension. It can be given in the breastfeeding region. It can be given postnatally. The side effects are tachycardia and contraindication is asthma. Methyl dopa alpha 2 agonist. Yes, it can be given during pregnancy, first trimester, and the longest post-marketing surveillance data is available. There is no known evidence of harm in the breastfeeding area. NICE says to avoid postpartum. Side effects are depression, reduced variability on CTG, methyl dopa hepatitis, and the contraindications are mental health disorders and hepatic disease. Hydralazine is a vasodilator. It can be used during pregnancy. It is used IV for rapid blood pressure control, may be associated with neonatal thrombocytopenia. There is a long history of use. Avoid rapid IV bolus because of risk of hypertension. It is excreted in the breast milk at levels too low to be harmful. It can be given in the postnatal period. There are no side effects or contraindications. Nifedipine, it's a calcium channel blocker, can be given after 20 weeks, available in short-acting forms for rapid blood pressure control and long-acting for long-term maintenance therapy, may be used simultaneously with magnesium sulfate. It may inhibit labor. It can be used in the breastfeeding period. Manufacturers advise avoid. There are no known evidence of harm. Amount of breast milk are too small to be harmful. It can be used in the postnatal period. The side effects are headache. Severe preeclampsia, maternal and fetal monitoring during expectant management, maternal assessment, vital signs, fluid intake, urine output should be monitored every 8 hours. Symptoms of severe preeclampsia should be monitored at least every 8 hours. Presence of contractions, rupture of membranes, abdominal pain or bleeding should be monitored every 8 hours. Laboratory testing should be performed daily. In the fetus, kick count, NST, uterine contraction should be monitored. Biophysical profile twice weekly. Serial fetal growth should be performed every 2 weeks. An umbilical artery Doppler study should be performed every 2 weeks. Fetal growth restriction should be monitored. Antenatal corticosteroids for accelerating fetal lung maturation for women at risk of preterm birth. Women with severe preeclampsia receiving expected management at 34, 7 weeks or less of gestation, corticosteroid therapy results in less frequency of RDS, neonatal death, and intraventricular hemorrhage. Do women with preeclampsia and their babies benefit from magnesium sulfate? The MAGPIE trial, a randomized placebo-controlled trial, where there was 50 to 67% reduction in risk of seizures, reduction in the risk of maternal death, may have some benefit to the baby. A dose of 4 grams loading dose with a maintenance of 1 gram per hour, monitoring observation of urine output, respiratory rate, and deep tendon reflexes. The timing of delivery, less than 34 weeks of gestational, stable maternal fetal conditions, continuation of pregnancy should be undertaken only at facilities with adequate maternal and neonatal intensive care resources. More than 34 weeks of gestation, unstable maternal fetal conditions, delivery soon after maternal stabilization is recommended. Delivery decisions should not be based on the amount of proteinuria or change in the amount of proteinuria. Delivery once maternal condition is stable, corticosteroids, magnesium sulfate prophylaxis, antihypertensive medication, ultrasonographic monitoring of fetal heart rate, symptoms, and laboratory tests. Contraindication to continued expectant management is eclampsia, pulmonary edema, disseminated intravenous coagulopathy, uncontrollable severe hypertension, non-viable fetus, abnormal fetal test results, abruptio placenta, and intrapartum fetal demise. Corticosteroids for maturation, delivery after 48 hours if the gestation is 33 weeks plus or minus 5 to 7 days, if there are persistent symptoms of HELLP syndrome, fetal growth retardation, severe oligohydramnios, reversed end diastolic blood flow, labor or premature rupture of membranes, significant renal dysfunction. Expectant management is given when facilities for adequate maternal and neonatal intensive care are there. Fetal viability of 33 plus minus 6 to 7 days. Inpatient only patient. Stop magnesium sulfate. Daily maternal fetal tests, vital signs, symptoms, blood test, oral antihypertensive drugs. Delivery can be done if the achievement of 34 plus weeks are done. New onset contraindications to expectant management. Abnormal maternal fetal test results. Labor or premature rupture of membranes. Eclampsia. As you can see in the picture, preeclampsia converting into eclampsia, where you can see convulsions, proteinuria, occurrence of generalized tonic-clonic convulsions or coma in women with preeclampsia, which cannot be attributed to other causes. The maternal mortality is 4 to 6% and the perinatal loss is 45%. Incidence may be 1 to 55 of all pregnancies in India. Most common in the last trimester, becomes increasingly more frequent as term approaches and may occur up to more than 48 hours postpartum. High fever in eclampsia is a grave sign, which may be the consequence of central nervous system hemorrhage. Major complications are placental abruption, neurological deficit, aspiration pneumonia, pulmonary edema, cardiopulmonary arrest, and acute renal failure and maternal death. Management is stabilization of the mother through application of a standardized ABCD, airway breathing, circulation, disability, and evaluate approach. If eclamptic seizure not terminated by itself, magnesium sulfate should be commenced as soon as possible. Further bolus of magnesium sulfate may be given and the maintenance infusion may be increased to 2 grams per hour. Hypertension should be controlled as discussed previously. Recurrent seizures may warrant intubation and paralysis in order to maintain oxygenation. Fetal bradycardia may be seen in cardiotocography, but seizure and beeper control is the primary intervention. As soon as the mother's condition is stable, she should be delivered by most expedient route, may be achievable vaginally, but most commonly by cesarean section. Effects of increasing plasma levels of magnesium while giving magnesium sulfate therapy. The therapeutic level is 4 to 7. 10 milliequivalents, patellar reflexes disappear. More than 10, there can be respiratory depression. And 12, severe respiratory depression treated with prompt endotracheal intubation and mechanical ventilation. HELLP syndrome, severe preeclampsia complicated by hemolysis, elevated liver enzymes, and low platelets occurs in 12% of pregnancies complicated by preeclampsia or eclampsia. Laboratory findings are hemolysis, abnormal peripheral smear, total bilirubin of more than 1.2 milligram per deciliter, LDH more than 600 international units, raised liver enzymes, and a low platelet count. Stabilize the mother, control the BP, prevent seizures, evaluate fetus for well-being, determine optimal timing and route of delivery as soon as possible, provide continuous monitoring and management during postpartum period, and all the parturient should receive magnesium sulfate. Alternative therapies are dexamethasone when platelet is less than 1 lakh, platelets for active bleeding, or if less than 20,000, plasmapheresis has limited success. Anesthetic implications, careful pre-anesthetic assessment is required for airway edema and compromise, aspiration prophylaxis, auscultation of lungs for pulmonary edema, fluid balance with correction of hemoconcentration, hemodynamic status, left uterine displacement causing uterine vascular hypertension, renal function and coagulation status should be assessed. Analgesia for labor should be provided with the placement of continuous lumbar epidural catheter. Decreased circulating catecholamines, less uterine vasculature resistance with improved uteroplacental blood flow may avoid the risk of general anesthesia. Anesthetics for delivery, non-emergent cesarean section, epidural anesthesia or spinal anesthesia. Epidural if previously placed and well functioning, spinal if no epidural placed and fetal heart rate is stable. General anesthesia if there is coagulopathy, patient refuses, and fetal bradycardia. By immediately instituting aspiration precautions, careful airway assessment, selection of technique, regional anesthesia given when hypertension and when platelet count is 80 to 1 lakh, airway breathing circulation, and control of BP with drugs required to control seizure. Neuraxial anesthetic technique, preferably to GA for elective cesarean delivery in absence of HELLP syndrome, reduces serum catecholamines levels, improves uteroplacental blood flow, improves intervillous blood flow in the preeclamptic parturients by decreasing the uteroplacental resistance. It is associated with better ABGAS score at 1 and 5 minutes compared to systemic opioids. In absence of contraindication like HELLP syndrome, coagulopathy, and thromboelastography, neuraxial anesthesia is preferred for cesarean birth. In preeclampsia, and lumbar neuraxial anesthesia is appropriate in preeclampsia during labor. Future health risk and screening. Future risks. Women who have had hypertensive complication in pregnancy receive postnatal counseling regarding the management of future pregnancies. Women with gestational hypertension, the risk of recurrence of hypertension in the next pregnancy is 16 to 47%, and of preeclampsia is 2 to 7%. Women with preeclampsia, there is a risk of recurrence 16% if delivered at term, and 25% if delivered less than 34 weeks, and 55% if they delivered less than 28 weeks. It is advised to book early in their next pregnancy. Consideration of starting low-dose aspirin as prophylaxis. Women on long-term antihypertensive therapy should be counseled to stabilize the blood pressure before conceiving. Should have more frequent blood pressure and urine dipstick monitoring. If they are delivered at less than 34 weeks, screened for antiphospholipid syndrome. Also, I have seen an association with HIV and hypertension. Associated adverse outcomes demonstrated by meta-analysis, increased risk of cardiovascular disease, chronic hypertension, venous thromboembolism, cerebrovascular disease. A simple lifestyle modification suggested by obstetric team, primary care by the physician to help reduce future risk are weight loss, smoking cessation, low salt, regular exercise, increasing the potassium intake. Thank you.
Thank you so much, ma'am, for a wonderful talk. I hope this talk is going to help all the participants who have joined this session on their practice also. Ma'am, we have received some question. If you allow, with all your permission, shall we take this question? Yeah,
Yes.
the first question I can see is the question is, what is the indication for ultrasonography and cardio topography in the evolution of preeclampsia?
See, ultrasonography is regularly done to all patients who are pregnant. It is done at 3 months, it is done at 5 months, and can be done frequently to see the blood flow to the fetus, also to see the amount of liquor around the baby, and to see the growth restriction of the child.
Ma'am, thank you so much for answering, ma'am. Moving forward, I can see a few more questions are there. I will be taking the last second question. This question is, what is the correlation between body weight and preeclampsia?
Obesity is one of the triggering factors for hypertension. That is why body weight should be controlled before pregnancy. It can also be associated with diabetes. So a good initiation, that is reduce weight before getting pregnant.
Okay, thank you so much, ma'am, for explaining it really well, ma'am. I can see, ma'am, there are a couple of questions. We will be taking last two questions for today's session. And the question is, which medications are used for blood pressure control in preeclampsia?
Labetalol is used. Labetalol is safe. See, people have been using drugs besides methyl dopa also has been used in the past, but labetalol is safest. Also, you have IV labetalol, so you get good control of BP. And if it doesn't control, then Nicardia retard tablet can be added.
Okay, thank you so much, ma'am, answering it. I hope that viewers have received his answer. I can see the last question is which risk factor have a major role in etiology of preeclampsia?
See, there are multiple risk factors. Obesity is one of them. History of antiphospholipid antibodies in the blood should be seen. Then history of diabetes should be seen. Then family history of preeclampsia should be known. History of preeclampsia in previous pregnancy should be judged. Elderly patient with twins, all these have a combined effect on the situation of the patient. So everything should be assessed when you get the patient on the first visit itself. Also measuring BP and giving good advice to the patient. Patient should be generally kept in a dark room without much lights so that there is no trigger. Patient's BP should be monitored regularly. I have seen patients who have had sudden fetal death. Okay, they used to come to me till the 9th month. In the 9th month, they would go to the village and they would come back with no baby. So this has happened twice with one of my patients. On the third time, I said, you wait in Bombay, I will deliver you. And every day we used to monitor her BP twice a day. She used to come and we could manage to give her a full-term baby because we could monitor her very closely. So close monitoring is very important because sudden fetal death is known to occur in this.
Okay, thank you so much, ma'am, for explaining this question with your personal experience, ma'am. It was a very wonderful session from your end. I hope that this is going to help once again all the participant, ma'am. Ma'am, as there is no more question from the participant end, with all your permission, shall we conclude this session?
Thank you so
Okay.
much.
Welcome, ma'am, and take care of yourself and hope to see you again with different topic in coming times, ma'am. Till then, take care. Thank you so much once again. We are closing.